I'm Dr. Ron Berkman, and this is part one of a two-part series where we will be reviewing aspects of shoulder dystocia. This first part will look at some of the epidemiology as well as the definition. The second part will deal with documentation and strategies to improve overall outcomes should a shoulder dystocia occur. First, I need to indicate that I have nothing to disclose. I do not receive any support for this particular discussion. So let's look at the definition of shoulder dystocia. The most widely utilized definition is as shown in the first bullet. That is, a vaginal delivery requiring additional maneuvers following failure of gentle traction on the fetal head to deliver the shoulders. This is clearly an operational definition and is the most widely used of the definitions. Others have suggested being more objective by putting a time frame to it, such as 1 minute, but that latter approach has not caught on, and I think most of us utilize the definition indicated under the first bullet. If we look at the epidemiology, the whole epidemiology of shoulder dystocia has undergone a great deal of study. And certainly much of this has helped us to some degree, but not as much as I think we would like it to. From the standpoint of the frequency of shoulder dystocia, and this is data from a recent ACOG bulletins published a bit ago, as well as from a neonatal brachial plexus task force that also reviewed the literature relating to brachial plexus palsy in the neonate as well as shoulder dystocia. So that the frequency of shoulder dystocia ranges between less than 1% to as much as 3% of vertex deliveries, with higher rates seen with increasing fetal weight, particularly in diabetic women. There can be maternal complications associated with this obstetrical issue, such as around an 11% rate of postpartum hemorrhage and almost a 4% rate of fourth-degree laceration, likely due to trying to do some of the maneuvers, such as a posterior arm delivery or a Woods maneuver. Most of us are well aware of the concern that all of us have are the neonatal complications, with an incidence of brachial plexus injury in the neonate ranging between 4 and 40%. The higher incidence probably relates to units where only the more severe shoulder dystocias happen to be reported. It also has to be important to recognize that 10 to 15% of cases will have persistent injury, but on the flip side, the majority obviously do not. There can be fractures of the clavicle and humerus in addition to stretch of the brachial plexus, and this is usually due to injury that occurs attempting to deliver the baby, such as the posterior arm delivery. And in severe cases, one can have asphyxia and even death of the fetus. Many risk factors have been studied, and some are listed here. Highlighted in the yellow are ones that we'll discuss in a little more detail. But certainly fetal macrosomia, diabetes, the interaction between these two is important, as well as maternal obesity, multiparity, post-term gestation. All of this probably relates to bigger fetuses. Prior macrosomia and prior shoulder dystocia are among many of the antepartum risk factors that have been evaluated. Intrapartum risk factors include labor induction, epidural anesthesia, use of operative vaginal delivery, and the length of the second stage has also been studied. It's important to recognize in any event that most of these risk factors do not have a high enough predictive value to be useful clinically. If we look, for example, at data from this recent task force of ACOG, you can see that in an evaluation of 10 studies looking at shoulder dystocia, you see a range of roughly 12% to almost 8% of birth weights being greater than 4,000 grams in the cases that were studied. When you look at even the bigger babies, greater than 4,500 grams, again, a wide range. And similarly, you see that with diabetes, again, indicating that you cannot utilize this entirely as a means to absolutely predict the likelihood of a shoulder dystocia. Other risk factors associated here with neonatal brachial plexus palsy. Second stage greater than 2 hours, about 17% if you look at the mean in these 6 studies. A short second stage of less than 20 minutes, 22% had this association. Again, not enough that you can clearly have any thought that any of this could be necessarily etiologic. Use of vacuum and forceps, as shown here, seen in about 20% of cases. You see certainly a much higher association with oxytocin use, but oxytocin is widely used in deliveries for stimulating labor and inducing labor, so this is likely purely an association, certainly nothing etiologic. And we can see that we do see brachial plexus palsy when labor induction is carried out. If we look at the relationship in a diabetic and non-diabetic, and here we're looking at the proportion of cases based on birth weight, you can see when we look at the diabetic in the yellow that as the birth weight certainly goes up, clearly the proportion of shoulder dystocia cases in diabetics are clearly associated with larger babies. In this particular two studies indicated here, you can see that when a birth weight is greater than 4,500 grams, over 50% of the cases of shoulder dystocia in diabetics occur in babies of this size. Now, the reverse is somewhat true with the green, which is the non-diabetics. If you look at birth weights less than 4,000, close to 50% of the shoulder dystocia cases occur with these birth weights, indicating again one cannot use the size of the baby as a predictor of shoulder dystocia, in that shoulder dystocia can occur in infants of any size. Other comments about macrosomia. If you decide that you wanted to do a cesarean section for infants of non-diabetic mothers where the birth weight is estimated to be more than 4,500 grams, well, you would only prevent about 20% of the shoulder dystocia cases. What about doing induction for macrosomia? And the observational studies that have been published suggest that the frequency of shoulder dystocia is not reduced. However, the rate of cesarean section is increased compared to women who are managed expectantly. However, ACOG in its recent, from the task force as well as in its prior practice bulletin, suggests that prophylactic cesarean section could be discussed with diabetic women who have estimated fetal weights greater than 4,500 grams or non-diabetic women with estimated fetal weights greater than 5,000 grams. However, the supporting evidence towards saying this is a reasonable strategy is at best fair. What about mode of delivery and the occurrence of shoulder dystocia and brachial plexus palsy? And these are three studies, again, going back a number of years, all the way up to a review done by the ACOG task force recently. If we look at the results from the task force review, here they looked at 12 studies trying to determine how often does brachial plexus palsy occur in the absence of shoulder dystocia. In the studies, there are approximately 1.6 million deliveries, over 3,000 cases of brachial plexus palsy, and they determined that about 46% as a mean of brachial plexus palsy cases are not associated with shoulder dystocia. Again, a wide range, but shoulder dystocia is not a prerequisite for brachial plexus palsy types of injuries. Further, when brachial plexus palsy injuries lasted more than 1 year, about 26% of the cases had occurred in the absence of shoulder dystocia. A California database study also looked at a large number of deliveries, nearly 580,000 confined and nulliparous women without breech presentation in the years 92 to 94. And they determined, as shown here, the incidence of brachial plexus palsy is about 8 per 10,000 infants with a spontaneous delivery, goes up markedly with operative vaginal delivery by 2 to 4-fold, but as shown, one can even see brachial plexus palsy injury in infants delivered by cesarean section, whether or not labor had occurred in association with that delivery. Johns Hopkins database studies suggest that also brachial plexus palsy can occur in the absence of shoulder dystocia, but again, in their case series of over 23,000 deliveries beyond 34 weeks of gestation, Brachial plexus palsy in the non-shoulder dystocia cases was quite uncommon, 75 times less likely. Permanent brachial plexus palsy was also rare in those cases, and risk factors really weren't helpful in that the weights were roughly average. There was more fetal acidosis and more posterior arm involvement, however. What about the forces of labor, and how do they link to neonatal brachial plexus palsy? As shown here in a variety of studies done with special force instruments and simulations, you can see that the endogenous forces of labor, such as contractions and pushing, put significant force on the fetal shoulder, head, in the neighborhood of well over 100 newtons of force. When you look at what the provider does, however, with, again, traction and the like, you can see that in general the forces which are exogenous in nature are substantially less than that which are endogenous, again suggesting that some of the injury certainly can be due to forces that occur during the descent of the fetus and not necessarily by the forces that are exerted by the operator. So what are the theories that explain this type of non-shoulder dystocia-related brachial plexus palsy? Fetal acidosis may decrease muscle tone, such that it alters the body orientation during descent, leading to stretch injury. Fetal acidosis, by decreasing muscle tone, may make the fetus more vulnerable when normal traction is applied during delivery. Asynclitism could do similar things of changing how the orientation is, leading to a risk of stress. And again, pressure on the posterior arm and unusual expulsive forces can also lead to stretch or compression injury. If you look at risk factors for recurrent shoulder dystocia, this is a study done in the state of Washington a number of years ago, and they determined that recurrent shoulder dystocia occurred in about 12% of women who underwent subsequent vaginal delivery. The risk factors that they identified included prior severe shoulder dystocia, birth weights greater than 3,500, and the use of vacuum delivery. What about the maneuvers that we utilize to release a shoulder that's been entrapped under the anterior symphysis? Basically, there is no algorithm that is felt to be the best approach. All of us sort of develop various approaches, and I will review these maneuvers at the time of the actual discussion at the annual clinical meeting. But when you have a shoulder dystocia, an algorithm that you might use is first to recognize that the dystocia is occurring. You have the mother stop bearing down. You do not have any more traction in order to reduce the impaction that would occur of the anterior shoulder against the symphysis. You also communicate with staff and the patient to take control of the situation. You call for help. In general, people will utilize the McRoberts maneuver since it's simple to do. Occasionally, episiotomy may be performed at this stage of the algorithm, particularly if one feels you have a significant shoulder dystocia and have to do secondary maneuvers. Suprapubic pressure is usually carried out in conjunction with McRoberts as needed, and or can be done in conjunction with the Rubens maneuver. At this point, one can consider delivery of the posterior arm or progress to the Woods corkscrew maneuver, repeating these maneuvers if needed if delivery is not accomplished. And finally, one can utilize the Gaskin or the Zavanelli maneuver in cesarean section. So this concludes this particular section. The second part will be a review, as I indicated, of documentation and means of reducing risk during the delivery process.